Good afternoon. First of all, would like to thank Dr. Stein for the introduction, and a special thanks goes to Mrs. O'Keefe for the organization of today's meeting. Thank you. So I'm very honored and proud to present this work, to represent the 3 years experience of redo anti-reflux surgery after failed fundoplication at the Northern Thoracic Institute in Phoenix, Arizona, the center where I had the possibility to undertake my fellowship. My co-authors and I have nothing to disclose. So laparoscopic fundoplication represents actually the gold standard for the definite treatment of gastroesophageal reflux disease, and for this procedure, excellent long-term results and high patient satisfaction had actually already been reported. However, we also know that in 2 to 30% of the cases, a surgical failure may occur, and this patient complains mostly of recurrent GERD symptoms or dysphagia. The majority of them, the symptoms can be managed with a medical therapy or with an endoscopic intervention. However, in 3 to 6% of the cases, a surgical revision is required, and mostly because of an anatomic issue, so such a recurrent hiatal hernia, slipped or disrupted fundoplication, or even because of esophageal dysmotility disorders. So the traditional approach, of course, is to undertake a redo fundoplication that surely represents a good and feasible option in most of the cases. But we have to remember that it's technically more difficult, and we also know from the literature that the outcomes are less satisfactory than a primary fundoplication. Therefore, as alternative, a Roux-En-Y diversion can be offered to this patient. This procedure is well described in the literature as well, and as a remedial procedure for failed fundoplication for the specific indication. It has especially been proposed for a patient with morbid obesity, with esophageal dysmotility or delayed gastric emptying, or even if a damaged EGJ or a gastric fundus could be spotted intraoperatively, because it wouldn't allow a refundoplication. However, the reported morbidity is significantly higher for this procedure, and for this reason, probably Roux-En-Y is more commonly considered more as a rescue option after several failures. So here I have summarized a list of previous publication, and the first 2 examples represent the first experiences made by my head, Dr. Mittel, at Creighton University in Omaha, Nebraska. And as we can see in his series, the first series, more than 1/3 of the patient had 2 or more previous fundoplication before undergoing Roux-En-Y. And again, 1/3 or more than 1/3 of the patient developed a complication postoperatively. And the same or similar results have been also reported by other major centers in the United States. So almost 10 years later, after the first experiences, we decided to retrospectively review the experience made over 3 years at the NTI in Phoenix to spot if something changed in the results and also in the approach. So after IRB approval, we retrospectively reviewed after our prospectively maintained database for data on patients who underwent both redo fundoplication and Roux-En-Y diversions. All procedures were performed by Dr. Mittel, and we excluded all patients who had previous non-fundoplication procedures, such as LINX, DIF, or endostim, who had previous bariatric or oncologic foregut surgeries, or incomplete, in the case of an incomplete data. These data points were queried, so demographics, pre-operative World Cup, operational data, perioperative morbidity and mortality, and of course also follow-up as a midterm follow-up. A total of 43 patients could be identified, 28 who underwent refundoplication and 15 Roux-En-Y diversion. There was no significant difference in gender or age, but the subject, as as expected, who underwent Roux-En-Y had a significantly higher BMI. Interestingly, in this series, the number of previous surgeries was similar between the groups, and we think that it was a result of probably was this as a result of a more aggressive use of Roux-En-Y at an earlier point in the disease history. With regard to visibility, we found no difference between the two procedures, so both Re-Fundo and Roux-En-Y could be performed laparoscopically without great problems, and actually the conversion rate was slightly higher for Re-Fundo rather than Roux-En-Y, but it was not significant, the difference. And now the morbidity, so intraoperative complications such as bleedings or hollow organs perforations were rare, and the difference was not significant between the groups. Postoperative complications were categorized according to the Clavien-Dindo classification, and as we can observe here in the table, there was no significant difference here either. The midterm results were evaluated with a GERD high-related quality of life questionnaire at a mean follow-up of approximately 1.5 years. A significant score improvement could be observed for both procedures. So in conclusion, at our best knowledge, at least for the first time, we could assess that Roux-En-Y diversion can be actually considered as safe as Fundoplication with similar results. And the present study suggested us that surgical expertise has been probably playing a big role in the identification of those patients who require a more aggressive strategy at an earlier point in the disease history. And this was probably the key point that led us to improve outcomes for Roux-En-Y diversion. Thank you.
Thank you for a very, very nice presentation. The assigned discussant is Dr. Roche.
Good afternoon. I would like to thank Dr. Giolini for an excellent presentation and a very, very important topic. I have three main questions. The first question is in regards to your preoperative workup. Did all your patients undergo a manometry, an EGD, a pH metry to confirm that they have a recurrence of their reflux and to study the indication for their failure? And how did they affect and impact the type of surgery you offered? My second question is more about intraoperative decision making. Did you sometimes go thinking that you were going to do a redo and switch to a Roux-En-Y diversion? And if so, do you think that those patients do have worse outcome post-operatively? And my last question is about long-term outcomes. Other studies have shown that there's a recurrence of reflux even after Roux-En-Y Roux-En-Y diversion. So I was thinking, what do you think the indication for Roux-En-Y diversion are, in your opinion? And what do you offer to those patients who recur after Roux-En-Y diversion?
Thank you for the question, Dr. Ross. So regarding the preoperative workup, so the goal of our center is to take every patient through a standard workup, which is a pH study, manometry, and also barium esophagram, which we think that is one of the most important preoperative studies. Of course, if the patient have a high grade symptoms, and if we know that they had already a long history, then also in our situation, also we decided to indicate Roux-En-Y as a kind of rescue option, because we don't have any other opportunity, of course. But with the time, so through the years, so we could identify some factors influencing. So we could say they might a Roux-En-Y at an early point could be better for, of course, for patients with obesity, because you can, even if it's not a bariatric procedure, we saw also in our results at the midterm also a reduction of the BMI, which is also affecting the outcomes, of course. But of course, it was a retrospective study, so we cannot really say. So we used this retrospective study in our results in order to look forward and to say, okay, we have to identify those factors, so who might be important to indicate Roux-En-Y at an earlier point. Intraoperatively, of course, so goal is every patient who undergo a revisional surgery, even if planned for a redo fundoplication, need to be informed that it might be that the strategy might be changed intraoperatively, because if the fundus is damaged, if the perfusion of the gastric fundus is not optimal, so they might require, or if the EGJ is damaged, they might require even, for example, an esophagoinostomy, so without any pouch. So, and they have to be informed about this. But sometimes these patients are thankful because their quality of life before is already at a low level. So I don't think that is a great issue. So if we inform our patient in a right way. And regarding the long-term outcomes, of course, so there are some patients who are also requiring, again, revisional surgeries also after Roux-En-Y. The way we proceed now, so the way we proceed, Dr. Mittels, and it's something that changed in the years, is that we leave the gastric remnant in place. So we do not perform gastrectomy of the distal stomach. In a case we need to perform esophagectomy as a last chance. And we had already in our seizures a patient who had to undergo esophagectomy for terminal esophageal disease, and it was possible to reconstruct the gastric pathway with a gastric conduit, because it was still there. The gastric remnant was still there. So this is one of the points.
I think we're going to have to move on. Thank you, Dr. Giuliani.